is medical malpractice insurance more expensive for, and anybody can answer this, for general practitioners than it is for specialists?
Oh, no.
It's not.
No, it's not, but, excuse me.
Go ahead.
One of the things goes to also what you were saying. I used to do vasectomies in my practice. However, when I applied for medical malpractice, they gave me the same rate doing that one procedure as if I were doing urology with very extensive urological operations in the OR. That made no sense. So I had to stop doing that service for my community because I simply couldn't afford. So in some ways, if we do the full gamut of what we've been trained to do, then actually we are bound by the higher cost, even though our rate of negative outcomes is obviously then far less.
Mm-hmm.
Well, I'd like to address that from a local standpoint. I mean, the private practice model of neurosurgery in the Philadelphia area has gone away. And it's gone away because neurosurgeons are asked to pay $300,000 per year for minimal liability coverage. That's their insurance fee. So by the time they pay, office rent and secretarial help and nurses and record keepers and $300,000 off the top for an annual insurance fee, they can't make ends meet. So they've become hospital employees. They've joined large academic groups. There are ways that they've adjusted to this. But the malpractice premiums for some of the surgical specialties are truly astonishing.
Next question, and Dr. Harbaugh, you touched on it, but is the shortage for all doctors, is it interest, is it students, or is it, because what you said was, it's residency. It doesn't matter if we have bigger medical schools, if we don't expand our residency program, we're still going to, the outcome's going to be the same. But do we have the students or the kids that are interested in medicine out there? Do we have the numbers?
I think there are always a lot more people who apply to medical school than get accepted. So, and many of the people who don't get accepted, I think, would make very fine physicians and are qualified. So if we expand the number of medical school training spots, we will turn out more medical students who have gotten their MD. The problem right now is, in order to practice independently, all of those students then need to go on and do a residency. If we don't increase the number of residency positions, we simply displace foreign medical graduates with American medical graduates, but the number of practicing physicians at the end of the day stays the same.
Still the same.
Okay, comment.
Dr. Sheldon.
We studied this when I was chairman of the Association of American Medical Colleges. Right now, only 64% of the doctors practicing in the United States actually went to medical school here. There's 32% more positions in residency than there are graduates of U.S. medical students. Most of them come from India. The second commonest group come from our offshore Caribbean schools. Those eventually get licensed, and if they go to a health services underrepresented area, 3 years they can get citizenship. So if we leave the residency group alone right now, and not get some of the funding changed, that's the bottleneck in the system at the moment.
Dr. Cow?
I think we have to make each subspecialty appealing to people. There have been studies done that show the amount of medical school debt implies the more likelihood to go to a subspecialty. Most physicians come out of medical school owing at least $100,000. And the kids these days are smart enough to figure that math out and do what works out economically rather than maybe works for their heart. In internal medicine, 10 years ago, the number of people going into primary care was 54%. Now it's down to 26%. So that's a dramatic change in the last 10 years. How can we change the reimbursement, the quality of life, the hassle factors? At my hospital now, I have to talk to 2 people before I can decide whether they can be admitted or an observation. That has nothing to do with what I do. It has to do with Medicare reimbursement. So it takes me about twice as long to make hospital rounds now as it used to.
Dr. High?
I think there are two other components when you're talking about students and medical school. One of it is we know from prior studies that there are certain types of medical students who are more likely to go into primary care. And there is actually ways that states have incentivized more students going into primary care. Their demographics are known. Medical school admissions committees who are aware of this can thus increase the number of students who are interested in primary care. And secondly, going to the mismatch, the currently unfilled slots in family medicine and in primary care is true. We have not been filling, which I think just highlights the fact that we need to turn around those incentives for students to go into primary care. But I would say that the current proposals are such that you have made changes that will start making students interested in primary care. So I would encourage you to continue to move those unfilled slots to primary care. You've created the incentive for them to want to be there. So don't then pull away the slots just at the time when you're telling them that they have a right to be interested and enthusiastic about primary care. Please keep those slots available for them to go into.
But, I mean, I appreciate the shortage in primary care, but we have acute shortages in surgical care as well, which will only get worse if we say that new residency spots must be restricted to primary care. We may make primary care better. I believe that would happen, but we will exacerbate what's already a shortage of surgical specialists. And if you look at the projections, the projected shortage of surgical specialists by 2025 is almost identical to the projected shortage of primary care physicians, and we can't make one problem dramatically worse at the expense of fixing another one.